Hello, welcome to our harm reduction, overdose prevention, and naloxone training presentation. My name is Kelsey, and I'm one of the public health nurses on the harm reduction team at the Grey Bruce Health Unit in Owen Sound. Before I continue, I would like to acknowledge that we are on the traditional territory of the Anishinaabe peoples. I wish to recognize the long history of First Nations and Métis peoples on this land. In particular, the neighboring communities of the Chippewas of Saugeen First Nation and Chippewas of Nawash Unceded First Nation. We work in a sector whose goal it is to address social harms, and we must recognize that the production of these harms comes from the long history of colonialism and its enduring practices, institutions, and ways of thinking. Colonialism is with us today, and we must commit to working in ways that reshape these institutions and practices, to repair harms, prevent future harms, and to work together to a more inclusive and just future. Here are some of the topics that we'll be discussing in our presentation. We'll be looking at substance use disorder, the opioid crisis, stigma, looking at what actually is harm reduction and what it entails. We'll be looking at opioids and having a further understanding of opioids. And we will also be looking at the poisoning prevention and naloxone training. Substance use is a common, complex phenomenon and exists on a continuum from beneficial use to low risk to high risk use to chronic dependence or substance use disorder. This continuum shows that people use drugs for many different reasons and in many different ways. Most Canadians use some psychoactive substance, for example alcohol, without social stigma related to their use or fear related to an unregulated supply. People move along the continuum for a variety of reasons, which we will discuss further in the accompanying slides. Researchers have tried to sort out the complex causes of substance use. One way is to ask which factors put people at risk and which protect them from developing substance use problems. Since substance use often begins in youth, research has focused on this age group. Risk factors for substance use problems in youth include alcohol or other drug problems among family members, poor school performance, poverty, family conflicts, chaos or stress, having friends who drink or use drugs such as peer pressure, not fitting in socially or being excluded because of factors such as race, ethnicity, gender, or sexual orientation, emotional, physical, or sexual abuse, experiencing discrimination or oppression. The protective factors for substance use problem include having a positive adult role model, good parental or other caregiver supervision, having a strong attachment to family, school, and community, having goals and dreams, and being involved in meaningful, well-supervised activities such as sports and volunteer work. At the end of the substance use continuum is chronic dependence or substance use disorder. What is substance use disorder or addiction? Substance use disorder or addiction is a diagnosable medical condition caused by repeated exposure to substances that changes brain biology, especially in areas related to motivation, cravings, and decision making. It overrides survival instinct in favor of drug-seeking behaviors. When a person uses a substance, it floods the brain with dopamine, a brain chemical linked with reward and pleasure. The immediate rewarding experience makes people to want to repeat it. With repeated use, the brain works to keep things in balance by developing tolerance, which is when more and more of the drug is needed for the desired effect. The brain also adapts by lowering the amount of dopamine that is available. This is why people who are living with a substance use disorder often report feeling flat or depressed without drugs. A person who develops physical dependence and then stops using may experience symptoms of withdrawal. Withdrawal can make a person feel very unwell and impair daily functioning. As a result, using substances may be a choice for some people, but for those with addiction issues, it really isn't a choice, and quitting may be extremely difficult, even with the support. What causes substance use disorder? There is no one cause of substance use disorder. It is the result of a combination of interwoven factors. Certain factors that contribute to the development of substance use concerns are beyond an individual's control. The social determinants of health, which are the non-medical factors that influence health outcomes, play a significant role in the chain of events that lead to substance use disorder. In this diagram, the roots of the tree represent systemic issues like capitalism, colonialism, and racism. These issues affect access to things like quality education, affordable housing, food security, and a healthy work environment. These factors in turn affect health and can lead to a range of unfair outcomes, such as a shortened life expectancy, poor mental health, and our topic of discussion today, problematic substance use. The opioid crisis can be considered through three lenses. Firstly, the overprescription of opioids has contributed to the opioid epidemic. In the 90s, drug companies encouraged doctors to prescribe opioids by playing down their addictive potential. This resulted in a four-fold increase of the opioid consumption in Canada. In 2012, a large group of people had their opioid prescriptions discontinued, but were still relying on this medication. This led to an unforeseen rise in the availability of synthetic opioids through the unregulated or illegal market. Secondly, the unregulated supply of drugs has become increasingly toxic with fentanyl and carfentanil. These are stronger drugs other than opioids, so they can be made and transported in smaller volumes, which reduces costs, increases profits, and decreases the risk of detection from law enforcement. Thirdly, stigma and criminalization. When it comes to the opioid epidemic, this crisis has roots in racism and oppression, and then the criminalization of people who use drugs. Indigenous, Black, and members of other groups of people are more impacted by drug criminalization. Groups that are disproportionately targeted are disproportionately harmed by the consequences of having a criminal record. We need to stop criminalizing addiction. Addiction is a health issue, it's not a criminal issue. As we can see from the statistics, the COVID-19 pandemic has worsened the pre-existing opioid crisis. The pandemic response has consisted of waves of public health restrictions of varying severity to help mitigate the spread of COVID-19. Despite the intention to reduce the impact of COVID-19, these restrictions have led to unintended harms. For example, there was reduced access to services for people who use drugs. Stress and anxiety fueled increased substance use as a coping mechanism. Border closures caused interruptions in the unregulated drug supply, which led to withdrawal and reduced tolerances. Street drugs became more unpredictable and increasingly toxic. Isolation led to more people using alone, which increased the risk of fatal overdoses. We want to briefly touch on how stigma contributes to the opioid crisis. Stigma is negative attitudes, beliefs, or behaviors about or towards a group of people because of their situation in life. It includes discrimination, prejudice, judgment, and stereotypes, which can isolate people who use drugs. People who use drugs face this stigma because of social and cultural beliefs about the use of certain drugs and current drug laws. Stigma also results from a lack of knowledge about addiction and how addiction works. Stigma is a major barrier that prevents people from seeking help and leads to people hiding their use and using in unsafe ways. It also negatively impacts care, treatment, and recovery from addiction. It affects a person's ability to find housing and jobs, which affects their health and quality of life. Language matters, and the words we use have power to set up walls or facilitate connection, especially when it comes to the topic of substance use. Using person-first language means simply saying the word person before whatever you are trying to describe. For example, referring to someone as an addict reduces their identity to their drug use. Instead, try saying person with a substance use disorder and notice how it changes the tone of the conversation. If you know the substance used, you can specify, for example, instead of saying alcoholic, say person with an alcohol use disorder. At first, I was confused when I learned that saying clean, to mean abstinent, is stigmatizing language, but the opposite of clean is dirty, and using substances does not make a person dirty. This slide isn't meant to be a list of rules of do's and don'ts, but I really hope it can encourage us all to think about how we can be intentional about the language we use to help reduce stigma and to break down those barriers. So how can we end stigma? Like we just talked about, we can use person-first language when talking about substance use. Using kind words can make it easier for someone to speak up, to feel understood, or to receive help. Reflect on your own attitudes and behaviors because they may be influenced by stereotypes, negative stories, and images of people who use drugs. Take some time to get to know people with lived or living experiences with substance use. Listen to their stories. Take opportunities to educate family and friends and challenge stereotypes. Maybe there was something from this presentation that stood out to you that you can share with others. Remember that addiction is a treatable medical condition, not a choice, and is deserving of medical care just like other health conditions. So really, what is harm reduction? Harm reduction involves reducing risks associated with their behavior or activity without requiring that people do not engage in that certain behavior or activity. People engage in harm reduction strategies in their everyday lives to minimize risks to themselves and others. Examples are shown on this slide. Every time we travel by car, we risk injury by motor vehicle accident, so we wear seatbelts to reduce the risk of injury. We use sunscreen when we're in the sun to reduce the risk of skin damage and skin cancer. Wearing blaze orange jackets reduces the risk of being mistaken for a game animal and shot while hunting. These are all examples of harm reduction. What is harm reduction? In the context of substance use, harm reduction is an evidence-based, person-centered approach that seeks to reduce the harms associated with substance use and improve health without requiring that people stop using drugs. The harm reduction approach is non-judgmental and supports the idea that people who use substances should have a wide selection of treatment options to meet their individual needs. This approach recognizes that abstinence and a one-size-fits-all approach does not work for everyone. Harm reduction is built on a belief in and respect for the rights of people who use drugs. Grey Bruce Health Unit's harm reduction services can be broken down into 4 programs: the needle syringe and naloxone programs, community outreach, and leadership of the Opioid Working Group. Through the needle syringe program, also known as NSP, we work with people who are using drugs to help them make their drug use as safe as it can be. Services are confidential and include the list on this slide. Another part of the needle syringe program is distributing supplies and providing ongoing support to our partner sites listed on our website. These sites are organizations such as pharmacies that have entered into contract with the health unit and provide our harm reduction services from their organizations. We are always looking to recruit new NSP sites to continuously expand the network of agencies offering harm reduction services throughout Grey Bruce. The naloxone program ensures naloxone is getting out in the community and into the hands of those who need it most. This program involves recruitment, training, and ongoing liaison with our partner naloxone distribution sites. We also offer harm reduction community outreach, which is to areas lacking harm reduction services. Additional ad hoc outreach is offered on a flexible basis in response to community overdose surges. The Grey Bruce Health Unit also provides leadership for the Opioid Working Group, a subgroup of the Community Drug and Alcohol Strategy, bringing together professionals and community members to address the opioid epidemic locally, as outlined in our Grey Bruce Opioid Response Plan, which is also available online. Opioids are medications primarily used to relieve pain. They can produce euphoria, making them prone to harmful use. Opioids are depressant drugs. They slow down the part of the brain that controls breathing. This chart lists some common opioids by the generic and brand names. You may have heard of some of these opioids like fentanyl, heroin, hydromorphone, and codeine, which are all used to relieve pain. Did you know that methadone and Suboxone, which are used to treat opioid use disorder, are also opioids? They are useful for treatment because they are long-lasting in the body, so their effect doesn't wear off quickly like fentanyl does. So this chart here compares the strength of different opioids to codeine or Tylenol-3, also known as T3s. For example, morphine is 10 times stronger than T3s. Fentanyl is about 100 times more deadly than morphine, which makes it an extremely dangerous drug. Canada's unregulated drug supply is increasingly becoming contaminated with fentanyl. The risk of accidental opioid poisoning from fentanyl is very high. There is no way to know how much fentanyl has been mixed into drugs because you can't see, smell, or taste it. Consuming as little as a few grains of salt worth of fentanyl can kill you. Fentanyl doesn't get evenly distributed throughout a batch of drugs, so the potency of one dose can be very different to the next dose. Additionally, nitazene opioids are newly emerging in the unregulated drug supply. Nitazenes can be up to 20 times stronger than fentanyl. Carfentanil was never intended for human consumption and is used by vets to tranquilize large animals. It is 100 times more deadly than fentanyl. So how can someone reduce the risk of opioid poisoning? Physical characteristics of the person can play a role, like weight, general health, and stress levels. How someone takes a drug affects how quickly it enters their bloodstream. For example, swallowing a pill is absorbed slower than inhaling a drug. Injecting a substance directly into the bloodstream is the fastest and highest risk for poisoning. We encourage people not to mix drugs. If someone takes an opioid with another depressant, the combined effects would further decrease breathing and lead to risk of overdose. People often think that mixing a depressant and a stimulant can balance each other out. But this is very dangerous because a depressant decreases breathing while a stimulant increases heart rate. A person's heart is demanding more oxygen, but the lungs can't provide it, which is a risk of overdose. Opioid tolerance takes weeks to months to increase, but can drop back down to baseline just after a few days of no use. If a person is abstinent while making a quit attempt or while in hospital or jail and then goes back to using their regular dose of an opioid, they are at a high risk of opioid poisoning. Statistically, there is an increased risk of overdose during the first 2 weeks after release from prison. People released from jail are now offered naloxone kits. We encourage people to start low and to go slow. And finally, using alone is a major risk for overdose. If a person loses consciousness, they cannot help themselves. We always encourage people to have a sober friend there, ready to respond with naloxone and to call 911. If a person is going to use alone, they can call the National Overdose Response Service. Someone will stay on the line and call for help if a person does not respond. The Brave app also will alert paramedics if a person is using alone and does not respond. So what is naloxone, also known as Narcan? Naloxone is a life-saving medication. It is easy to use and there is no risk of misuse. It will not cause harm even if given in the event when it is not an opioid overdose. Naloxone works by kicking opioids off the opioid receptors in the brain, which temporarily reverses the effects of an overdose. Naloxone starts to wear off after 30 to 90 minutes, depending on what substances were used. It is possible for an overdose to return even without taking more drugs, which is why it is imperative for the person to receive proper medical care after an overdose. Naloxone is available as injectable or nasal spray. Kits are available for free at most local pharmacies and through public health for anyone who is interested. So here are our 2 naloxone kits. So both kits include 2 doses of naloxone, instruction cards, gloves, and a one-way breather barrier. So we have the injectable kits, which are red, and we have our nasal kits, which are black. Naloxone is temperature and light sensitive. It should be stored in its case to avoid exposure to light. It should stay within room temperature, so it is not a good idea to store it in a car, particularly in winter and summer months. Naloxone has an expiration date, so you want to be aware of your kit's expiration date and get a replacement if your kit is past or near its expiration. If the only kit available to you has been exposed to extreme temperatures or has expired, it can still be used to reverse an overdose. As data suggests, it still may be effective. Opioids cause decreased breathing. With less oxygen getting to the body, this can lead to blue lips, nails or skin, cold and clammy skin, limp body, and unresponsiveness. Opioids can also cause pinpoint pupils. However, if someone has mixed stimulants with opioids, you may see other signs. The bottom line is that an opioid overdose, the person doesn't wake up to shouting or shaking. If you aren't sure what the cause is for someone's unconsciousness, it is safe to assume opioid poisoning and to give naloxone. So these are 5 steps to respond to an opioid overdose. The first step is to shout and shake. Call 911 is the second step. Third step is to give naloxone. Fourth step is to perform rescue breathing and/or chest compressions. Fifth step is to check to see if it's working. This is the same information that is in the naloxone kit. Let's look at each step in closer detail. Step 1, shout and shake. So you're going to shout their name and you're going to shake their shoulders. If they are not responding, assume it is because of opioid poisoning. Step 2, call 911. Opioid poisoning is a medical emergency. The Good Samaritan Drug Overdose Act was created to help encourage people to call 911 in the event of an overdose. It provides some legal protection for those on the scene. The Act can protect from charges for simple drug possession, breach of conditions regarding simple possession in, pretrial release, probation orders, conditional sentences, and parole. The Act does not provide legal protection against more serious offenses, such as outstanding warrants, production and trafficking of controlled substances, and all other crimes not outlined within the Act. Step 3 is to give naloxone. Nasal naloxone is a spray that goes in the nose. You want to tilt the person's head backwards so the spray does not drip out of their nose after it's administered. You want to be careful when handling the nasal spray not to push the plunger until it's in the person's nose. You're going to gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the bottom of the person's nose. You're going to press the plunger firmly to give the dose of naloxone. We're going to remove the nozzle from the nostril after giving the dose. Naloxone takes about 3 to 5 minutes to move from the nose through the bloodstream to the brain. Step 4, you're going to check to see if they're breathing. If the person is breathing, put them in the recovery position and stay with them. If the person is not breathing, perform rescue breathing and/or chest compressions, also known as CPR, depending on your training and your comfort level. Provide 5 cycles of compressions and 2 breaths. Push hard and push fast. Use gloves and the one-way breathing barrier provided in the kit. Step 5. After 2 to 3 minutes, you're going to check to see if it's working. If the person has not started to wake up, you're going to repeat steps 3 and 4. So you're going to give another dose of naloxone and continue CPR if necessary. Make sure that you stay with them. When naloxone takes effect, the person may wake up suddenly, wake up slowly, be disoriented, or confused. In any case, it is helpful to orientate the person to where they are and what time it is. The person may be experiencing mild to severe withdrawal symptoms, which is very uncomfortable. A person may want to use more drugs to help treat withdrawal symptoms. It is important to encourage the person not to use for a number of reasons. First, it will not be effective because naloxone is blocking the opioid receptors, so it will be a waste of a dose and a waste of money. Secondly, naloxone will start to wear off after 30 minutes, at which time there is a risk for a second overdose. Simply help the person get more comfortable by offering a place to sit or lie down. Offer a blanket or a drink of water. Responding to or witnessing an overdose can be very traumatic. It can be helpful to debrief with someone you trust and someone that you feel comfortable talking to, like a friend, a family member, or a professional counselor. Remember to replace any naloxone that was used so you can be ready to respond to future overdoses. To review again, the 5 steps to respond to an opioid overdose. You're going to shout and shake, call 911, give naloxone, and perform rescue breathing and/or chest compressions. And step number 5 is you're going to check if it's working. Always stay with them. So this concludes our presentation. If you have any questions, please explore the harm reduction pages of the Grey Bruce Health Unit on our website or contact a member of the harm reduction team.